Much. So I think here comes the worst part, which is the late sequelae of these infections that we treat. So we already talked about septic arthritis, and we all know that in the hip joint, these infections could have a very bad sequelae. And the delay of the diagnosis is only make it worse, the prognosis of these children. So the goal in every type of infections is to have the diagnosis less than 72 hours, because we know from the literature that up to 5 days we'll all end up with bad results. And the osteomyelitis or the septic arthritis could be primary or secondary, it was already being told. And the long-term effects of the initial treatment may differ or depend on the patient's age, the infecting organism, and the timing and adequacy of the initial surgical or clinical treatment of these patients. And the goals of our treatment when we deal with the late sequelae of the septic arthritis, especially of the hip, is to find stability, restore the anatomy, and have the limbs equal in the end. So we all know about the Choi classification of the sequelae of infections on the hip joint. And their the classification is based on how was the anatomy of the sequela, and based on this classification, Choi and his group made an algorithmic protocol of the treatment of the severe sequela of the infantile septic arthritis of the hip. And based on the ultrasound, the MRI, and the arthrogram, he classified this sequela in 5 types. And according to the sequela, some procedures are recommended. So this is the complete algorithm of the treatment. So in the type 1, we have basically a normal hip in type 1A, and in type 1B, we have a mild coxa magna. So very little must be done in these cases. In type 2, we have involvement of the epiphysis and the physis and the metaphysis. So type 2A, we have coxa brevis with femoral head deformity, and in type 2, we have progressive coxa valga. I'm trying to find the pointer. Oh. Okay. So the recommended procedures are realignment osteotomies, pelvic osteotomy, sometimes epiphysiodesis to address the leg length discrepancy, and the apophysiodesis of the great trochanter. So here we have a case of a child 2+8 and immediately post-op of the Chiari osteotomy just to cover this big femoral head that ends up after septic arthritis. Another case, this was a patient, very young patient, in the initial clinic X-ray showing the dislocation of the femoral head. This is the same patient with 7 years of age, so we recommend a realignment osteotomy and a pelvic osteotomy. In type 3, we have slipping the femoral neck, so we have in 3A a coxa valga or a coxa vara with severe anti or retroversion, and in type 3B, we have the pseudoarthrosis of the femoral neck. So depending on the deformity, we could do the femoral valgus osteotomy, the pseudoarthrosis repair, we address the leg length discrepancy, and we can move the great trochanter. So in this case of type 3A, this is the preoperative, so the AP view. We made a Lamston view to address the anteversion, and then adduction and abduction X-rays. So we perform a femoral valgus derotation osteotomy and a distal transfer of the great trochanter. Another patient at 11 months of age, showing the sequelae of the infection. The same patient with 10 years, showing a very severe deformity of the femoral head. This is the X-rays pre-op, AP, adduction and abduction. And this is the patient with 11, almost 12 years of age, femoral valgus derotation and distal greater trochanter transfer. And this is to show there's very little leg length discrepancy in the clinical picture. Another patient, type 3B, a very young baby, is at 2 months of age, 6 years, showing there is a pseudoarthrosis and the sequelae of the infection. So we did the repair of the pseudoarthrosis and the realignment. Another patient showing this type 3B, showing the pseudoarthrosis, and this is the result. The type 4, we have destruction of the femoral head and neck. Could be type A with a small median remnant of the neck, and type 4B with a complete loss of the femoral head and neck. In this case, is recommended open reduction, some kind of reconstruction. We used to do a colonal operation and the distal transfer of the great trochanter. So this was a boy. This is the X-ray when he was 4 and 9 years of age in November of 1990. And this is 14 years post-operative of the colonal operation. And he's still doing well with a pain-free hip. But in these cases, we have to plan to make more corrections or reconstruction. So it's recommended, especially from the coming from the Elizarov group and Paley group, to address these corrections and lengthening to compensate the leg length discrepancy that these severe sequelae usually leave in these patients. So this was a patient, 4.5, back in '89. She had a osteomyelitis of the whole femur. This is the X-ray with F. Burry, and this is the clinical picture. You can see a severe deformity on the knee joint also, and this is to have an idea of the leg length discrepancy of this patient, 14 centimeters. So it was planned to make osteotomies to correct, to realign, and then to lengthen. And this is the result 1 year, 1 month post-operative. When she was 9, she still had 6 centimeters of leg length discrepancy, and it was addressed. Another case, a 17 days baby with a neonatal infection. Here's the patient with 5 years, almost 6. It was we performed a trochanteroplasty, and this is the patient with 13 years of age, showing a huge leg length discrepancy. And the patient was submitted to a hip reconstruction using these external fixers, and this is the clinical picture. And this is the final result 3 years ago. We also could do in late sequelae of the infections in long bones. For example, this patient, after an osteomyelitis of the tibia, you can remove all the sick tissues in the area and make a tibialization of the fibula with a microsurgical procedure, which is being very useful in these cases too. In the upper extremities, we also have osteomyelitis that can go to the epiphysis, to the whole metaphyseal and diaphyseal area. This was one boy with this sequela, and he was submitted to reconstruction and lengthening to address the deformity, and this is the final result. the problem is that these patients could have multifocal infections, so they can present with infections in the upper extremities and in the lower extremities. So this was the patient back in 81, and this is 80 years after, showing the severe sequelae in both lower extremities. So this is the aspect of the hip joint of the left side. So it was done a Lawrence supporting osteotomy. And then there was this knee deformity because of the injury of the growth plate. And she was submitted to another realignment and lengthening. And this is the result of the lengthening, and this is the clinical picture. This was a boy sent to us because he had osteomyelitis, and then he had a fracture. Someone put an external fixer and sent to our department. So he arrived in this situation. The knee was dislocated because they tried to fix the infected fracture and tried to lengthen too fast, so the knee suffered. So we put him in a traction to reduce the knee. This is the clinical aspect. Please see the leg length discrepancy. So it was planned to realign and then to lengthen. We have to pay attention to fix the pelvis because it's very frequently to have this happening, the subluxation of the hip. And despite all the efforts to elongate after these infections, he ended up using a brace prosthesis to compensate the leg length discrepancy. So in conclusion, the key to treat this late sequelae of infections is to have a careful evaluation and individualize the planning of treatment to every patient. And thank you very much. And in the name of CCOT, I would like to thank our pediatric colleagues to be here, to come to our symposium. And I'm sure we are going to plan and be in Prague next year. Thank you.
Thank you very much. Any questions? A comment is, this is why we should detect these earlier. It's not nice for these children. Questions? It's all clear.